Okay, so what you see here is an organization of the Diagnostic and Statistical Manual, 5th edition, how it has the disorders organized. And they, as you can see, they have their 2 broad subheadings. So use your critical mind here. You can see that the DSM in this respect is regarding sex and gender as being binary. So already a little bit problematic. And you'll see some heterosexist stuff in this as well. So basically, it just goes down the list in Masters and Johnson's stages. Remember, we added desire phase onto the beginning, and Helen Singer Kaplan did that. And then there's arousal phase, orgasm phase, and then there's 2 disorders that don't fall into any phase. Now, males are slightly different than females in their disorders that can occur. For females, desire disorder and arousal phase, they were lumped into one. And that is because they found that most females don't really distinguish between desire and arousal. Wanting sex and being aroused by sex seem to sort of co-occur for women, and they're not really distinct. The orgasm phase, there's male orgasm phase disorder, female orgasm phase disorder. Both of those are about having trouble having an orgasm. And then there's another kind here that I'll come back to, genitopelvic pain / penetration disorder. Just say that 5 times fast. I'll tell you about this in a second. And then premature ejaculation does not have a correlate in women. So that's the coming too soon business. And I'll go over the definitions of all these things in a minute. But this is, I think, a good example of heterosexism here, because it's very heterosexual, if you will, that people don't care if women come too soon. Nobody cares about that. Well, people only complain when it's men. And I suspect, I'm not sure, but with some of the gay men that I've talked to, that premature ejaculation just isn't a problem in that community. Nobody really cares. They're just delighted if you come really fast. It's only really a problem in heteronormative intercourse. Genitopelvic pain / penetration disorder. Just a little note here that, let's see if I can do this. This used to be called different things for women. This is one of those disorders that's been combined. These 2 disorders, Dysperunia and Vaginismus, they used to be different. Dysperunia means broadly pain upon penetration. And vaginismus is the involuntary closure or tensing of the outer third of the vagina at penetration. Again, very heteronormative. The fact that we care about penetration is kind of, and we have a whole disorder for when something happens to penetration. At any rate, vaginismus, the involuntary closing of the outer third of the vagina, what they found is these 2 disorders, dysperunia and vaginismus, were so highly correlated it didn't make sense to call them something different, so they were combined into one disorder. And the disorder has the same name for male people. Okay, so let's go over these a little more individually. Going down the list here, desire disorders. There's been a lot written about desire disorders, and they can be quite painful to couples. But as you might imagine, there's been some disagreement by experts about how to define a desire disorder. About 33% of women, normal women, and 16% of normal men will say, I feel like I've had this at some point in my life. So it might just be some sort of normal variation. But nevertheless, it is still in the DSM. There's also a recognition that it's very, very context dependent. You could imagine that if 2 people only wanted sex once a year and those dates lined up, that this does not usually get a diagnosis. We usually don't pathologize that if the partner isn't upset. By the way, you might be thinking, what about asexuals? And that's a very good point. This could pathologize asexuals. if the partner was complaining. This set of disorders, desire disorders, may be the most context-specific of all the sexual dysfunctions. And it often is considered more of a relationship problem. It sometimes can signify boredom in the relationship, anger. I don't think my partner listens to my needs. And this is really up to the clinician's judgment to make a diagnosis within the context of the relationship. It's sometimes referred to as desire discrepancy disorder by clinicians as a way of demarking that it really is only a problem if there's a difference in the couple, not if they're the same and they want it 3 times a day or they want it 3 times a decade. It really doesn't rise to the level of a problem. Okay. In terms of male desire disorders, the male desire disorders can be extremely problematic in a heterosexual relationship. And think about it. What happens if a man in a heterosexual relationship, doesn't want sex anymore? What happens? What goes through the woman's mind? You probably can imagine she thinks, is he cheating? Does he not find me attractive? And those thoughts can be problematic. Interestingly, oftentimes you find that whether the male's having the problem or the female's having the problem, often in heterosexual relationships, the woman blames herself. It's very often not caused by low testosterone. A lot of times men think it's testosterone, but when you test it, their testosterone level is fine. It can be a symptom of a psychiatric disorder such as depression or anxiety. The treatment is very, very often just couples therapy, and you don't necessarily treat the sexual dysfunction per se, but you treat the relationship. So this particular problem causes a lot of problems in heterosexual relationships. Okay. Sexual arousal disorder. I'm not going to talk about female desire phase disorder. I'm just kind of talking about the ones we know the most about. Sexual arousal phase disorder in males. Sometimes it used to be called erectile dysfunction. We still sometimes call it that. And by the way, when they come out with a new manual in DSM, it doesn't mean that every clinician suddenly starts calling things by their new names. I mean, it's like, Asperger's syndrome was taken out of the DSM. It still exists in Europe, by the way. But we still use the term, right? It's not like clinicians just are going to change because the manual changed. So we often still call it this. And this is one of the more likely disorders to lead a man into treatment. But erectile dysfunction is fairly commonly reported in older men. And it seems to be more and more normal as you age. And what you find is that there's an inverse relationship between age and distress. I'm going to draw that for you and then restart. I can't seem to draw that, but at any rate, there's an inverse relationship between age and distress, where if you're young and you have erectile difficulties, you have a lot of distress. But if you're older, you're more like, I guess that's kind of normal. So something to look forward to. There are some really important organic etiologies to rule out here. Sometimes when a male person has a problem with arousal or getting an erection, it can be the first sign of more serious physical problems. For example, we don't completely understand this is my knowledge in 2020, why we don't understand why this connection, but for some men it can be one of the earliest signs you have of diabetes type 2. It also can be an early symptom of a heart problem. So it is important, again, I don't want to do CBT with somebody like this. I want to send them to a urologist or somebody who's going to check them out and who's going to rule out some medical problems before I do psychology treatment on them. So treating erectile dysfunction. There's a whole bunch of things that we can look at here. The most common way that most men get treated with this is these days, and we've already seen it in the lecture about aging and sexuality, but is oral medication. Viagra, Cialis. Very often men do not even see a psychologist. They just go to their doctor and say, "Hey doc, will you prescribe me some?" And they do, no big deal. Okay, there are other things. So there is good psychological treatment that I think actually is probably better in the long run for the man. There's some other things that I'll go over in a second. Vacuum devices, I'll show you some pictures of those. Injection of vasodilators, implants, and then there's some psychological treatments. Here's an example of a penis pump. We already saw this in enlarging the penis, but you can use it also, again, to get an erection if you're having problems. And remember, the advantages to this is that it's cheap. You don't have to have a doctor's prescription, and it's pretty effective. And remember, there's this rubber thing on the bottom there that once you've gotten an erection, once you've sucked the blood into the penis from the outside, you then roll the rubber thing onto the base of the penis. It acts, the sex toy that's analogous to this is called a cock ring, and it keeps the blood in while the man is having intercourse. And these are pretty good. They're just a little, they're cheap and all of that. They could be a little intrusive though. Here, and we've already seen this too with trans men, and also with penis enlargement surgery, is that you can put things inside the corpus callosum of the penis, and either they're filled with saline or maybe they're bendable, but they can help with an erection. Now, remember that the disadvantages to this are like the disadvantages to having surgery for penis enlargement, that you have to go under a general anesthetic, and there's always a risk there, and it's a last resort fix. Okay, so only with people that you've tried all kinds of other things, and it's truly medical and etiology do you want to do something like this, because it's expensive, intrusive, and all of that stuff. Here are the flexible rods. And, this person will never be able to have a natural erection. And when I come back, I'm going to tell you all about sensate focus and